Hi everyone, how are you going?
Good.
Okay.
How are you?
Good, good. I'll just share my screen. I'll just move pictures of everyone over. You should be able to see this now. Is that, you can see the little skeletons dancing?
Yep.
Okay, what's the time? We've got a few minutes. Is there any requests of anything that we go over this session before we start, or any comments on how it's going?
It's just a lot. A lot.
Hopefully, this session will break it down. I think in this tutorial, we're going to focus on the male structures, but we will go over the gastrointestinal tract very, very briefly, because we cover that more when we cover the abdomen. And we'll cover the urinary tract structures in the pelvis, and we revisit the urinary tract when we talk about that in the abdomen as well, because it's, you know, your kidneys, your ureters and your bladder and your urethra, and that's all connected, as your bowel is all connected as well. So nothing sort of stops and starts from abdomen to pelvis. It's sort of a continuous cavity, really. And then we're going to focus on these male structures today, and we'll do the female structures on Thursday. So was there anything that you found tricky about the male structures, or the bladder, or the anything like that?
Michelle, hello.
Mm-hmm.
I'm gonna be honest, I haven't watched all of the videos, so I've only watched a few of them, but
okay.
I'm still coming anyway.
That's okay, that's okay. We will go through it. I will, we're going to be more talking about what are the important things to focus on. So as long as you sort of know what we're talking about, that's okay. Just ask a question if you're not.
No worries. I did notice that some of the words were extremely tricky.
As I said, anatomy is like another language.
Yeah.
You will notice as we go through that you will see patterns in how things are described, and you will start to notice that we revisit the same things. So we don't just data dump things in 1 week. We will come back once we get to the abdomen. We'll still be looking back at the bladder. We'll still be looking back at the bowel. We'll still talk about some pelvic structures as well, because we'll follow those through.
No worries. Thank you.
Okay.
Sorry,
yeah.
I do have a quick question.
Yeah.
With the quiz that's in like 2 weeks, is there, so the practice quizzes are just the ones that you give us at the end of each week? You're not going to put anything else up for us to practice?
No, the quizzes, the way we go through looking at the images in these tutorials and study groups completely should prepare you. All the questions I'm asking you, what's this structure? That's the same thing that you're going to get asked in the quiz. It will be images, and it will have a whole lot of images selected and labeled, and you'll need to pick the most appropriate answer.
Okay, so right, it's so the same layout.
Yeah, it's exactly like what we're doing in these tutorials and study groups.
Okay, excellent.
Yeah, so your best revision for that quiz is just watch these again and go through, and if there's an image and you can't work it out, then you just look at that image and think, how am I going to quickly work that out? But yeah, this should totally prepare you for the quiz.
Okay,
you should see nothing in there that we haven't covered in the tutorials and study groups.
All right, I'm just panicking quietly on my own.
It shouldn't be images that you will think, oh, I've never seen that before.
Oh no, what I think it will be and what it is are generally two different things.
Right. It's
just the complexity.
It's a 10-question quiz, so you'll have 15 minutes for it. Mm-hmm. And you don't have to type any answers. It's just images with labels. Mm-hmm. But you need to read the labels and pick the most appropriate answer, really.
Okay. And that's open the entire day, or it's 9 a.m. has to be done?
No, it's open for 48 hours and you just have
Okay.
to find 15 minutes in that 48 hours to do it. You can do it right at the end, you can do it right at the beginning, or you can do it right in the middle. Doesn't matter.
Okay. I'm sure I'll just spend the rest of this degree panicking till I've actually graduated and sit there and wonder how the hell I actually got through it all.
I think people get a bit overwhelmed, but remember, by the time you're doing that quiz, it's in week 4 and it's just on the pelvis, and we've also developed a bit of looking at more images, so you start to get a little bit more used to looking at images. That's why we don't have the quiz at the end of the week 2. It gives you a bit of time to digest what we've talked about.
All right, excellent. Thank you.
Yeah.
So does it relate a bit to the images we have to label sort of thing?
The images, there'll be more images rather than diagrams. The diagrams in those images to label are just for you to think about where they sit on a diagram, and then allow you to think of where that on that diagram you're going to see it on a medical image as well.
Okay, thanks.
So yeah, but the things you're going through, some of those images to label have a few harder structures in there, but focus on the ones that we've gone through in here. I think this slide is fairly self-explanatory. The thing is to be able to look at these images without the labels and know exactly which is male and which is female. The key thing is that in the male, there's going to be sort of 2 canals. In the female, there is 3. The female has the uterus, the cervix and the vagina added, where that's not present in the male. And so you can see that the uterus sits in between the bladder and the bowel on the female, but there's nothing, well, actually there's seminal vesicles that sit in here, but not a whole other structure with an opening on the males. So this is what we're going to unpack and get you to develop this thought as we work through. You can see we've
Michelle,
yeah.
with the female, after they've had a hysterectomy, what does the top of the cervix look like in ultrasound? Does it have still the cervix visual, or is there a closure there, or what would you see?
When someone has a hysterectomy, the cervix is gone. All that's left is the vaginal vault, we call it. So then you'd have a vaginal, what we call cuff at the end, but the uterus and the cervix, which is this what we call distal opening of the uterus here, that's all taken out when someone has a hysterectomy. For those that don't understand, is when a woman has the uterus surgically removed. Ectomy means removal of. And so, yeah, so the only bit left would be this bit here. Does that make sense?
Yeah, I had a ultrasound yesterday, and he had the screen on for me, and I couldn't see the cuff at all. I didn't know, there was no definition there, so it was hard to tell what I was actually looking at. So I thought, what's it look like on ultrasound?
No, you probably don't see the distal end. We usually posterior to the bladder, you can see the vagina up to a point, and then it just sort of disappears unless you're overtly taking an image just of what we call a vaginal cuff. Yeah.
Okay, thank you.
Okay, so the gastrointestinal tract, when we're talking about the pelvis, we're only really going to mainly discuss in these tutorials and study groups the rectum and the anus, and we pointed those out in previous discussions. They do connect up, and if we go retrograde, meaning the opposite direction of which food would probably go, we're going to have the anus, which is the final passageway, which sort of sits below the level of this pelvic floor. And then above that, we will have the rectum, which is more sort of, you can sort of see it's sort of a straight section of the distal bowel here. And then above that, it becomes all a bit squiggly and it makes it look straight, but this sigmoid colon is more S-shaped. So think S-shaped for sigmoid. And then that's our large bowel, our large intestine or bowel, we can use the term, or you can use colon. And then more proximal to that, we have the small bowel or small intestine. So the small intestine is smaller in diameter, longer in length, but smaller in diameter. So the large and small refers to the diameter of the bowel. And so you just need to understand that the rectum connects up and is the distal sort of portion of the large bowel, which is this here. This is just a dodgy diagram of mine. How would you describe where the rectum sits within the pelvis relative to other organ structures, I suppose?
Posterior.
Posterior. So this is supposed to be your sacrum and your coccyx, and the rectum sits just anterior to that. So relative to these other organs, the rectum sits more posteriorly. So here's sort of our sacrum, and this thing here is our rectum. What's that black area within the rectum?
Gas.
Air, yeah, air. So that could be a little bit of poo there, and that's a bit of air. So in the bowel, we get a combination of air, that's very normal, and the digested food contents that have to be eliminated from the body. And so we're going to see combinations of air and food waste contents. When we do a CT scan, the bowel can often look very similar in density to other structures. So we often give the patients oral contrast. So I've told you that we give an injection of intravenous contrast, where we inject it into a vein in the arm to show the perfusion of arteries and veins and outline some organs. But to outline the bowel, we get the patients to drink some oral contrast, meaning it's going in their oral cavity, in their mouth, and they're going to sip on that. And so it's called barium, and it's like a white, chalky, disgusting, milky substance. It's not very nice, but they drink it and then it outlines their bowel. So when someone drinks something, it will go in their oral cavity, it will go down their esophagus, it will come through their stomach, through their duodenum, and then it will hit their small bowel first. And this is their small bowel. It's outlined here in this coronal CT scan. And then it has to make its way through the ileocecal junction and into the large bowel. Usually it's slower to get to the large bowel. So usually we see it in the small bowel. Can everyone see this is small bowel, and it has a smaller diameter caliber of the bowel? Sort of. We're going to have more large bowel here, which isn't opacified, has a little bit more air in it, and it's a larger caliber. So this is a CT scan. This patient probably didn't have oral contrast. You can see a bit of the small bowel and a bit of large bowel here. It's not easy to pick it out as easily on these images. The large bowel tends to sit more around the outside. So you've got some small bowel more in the inside. And can you see on this one, you can see the large bowel, it's got dark air in it, and it's a wider diameter capacity than this small bowel. Can you see how it's sitting a bit more peripherally as we've drawn? And you can see in these diagrams, and the small bowel sits more in the center as well. Can everyone see that?
So would that be superficially?
This here, yeah, well, certainly when we do an abdomen ultrasound and we put the probe superficially, this large bowel is sitting superficial to this small bowel here. We won't tend to see too much with ultrasound because we're going to hit this air, and the sound's going to hit this air soft tissue interface and reflect back. So we just see what we call dirty shadowing on ultrasound. And that's why ultrasound's not usually used to examine the bowel. We can use it to look a little bit at the bowel, but it's not a bowel investigatory tool as such. in special circumstances it is. We certainly look at the appendix, or look for the appendix, which is this little thing that pops off at the ileocecal junction. In this case, I would say that the bowel is sitting anterior to the small bowel. It's sort of circumferentially surrounding the small bowel. Certainly, if you're saying, where does this bit of the colon sit relative to this small bowel, that is superficial. Yeah, it's more closer to the surface. Yeah. So as I said, the rectum is that final bit. So you're going to have the sigmoid colon come down. You can sort of see it's a bit bendy, and then this straight distal bit of the colon is the rectum. It has a few little folds, but it's generally straight relative to the rest of the sections, and you can sort of see it coming down here. It's outlined by air in this. What sort of a view is this? This is an MR. What plane is this image acquired in?
Sagittal.
Sagittal, yep. So we can see L5, and we can see the sacrum, and we can see the rectum outlined by air, and then we know that we're going to see our pelvic floor muscles sort of come through this way, and then our anal canal, our distal canal, will be down inferior to the region of our pelvic floor muscles that we talked about last week. Everyone can see the pelvic floor muscles extending from sort of the sacrum to the pubic symphysis, rectum above that, and anus below that. Everyone seeing that?
Yeah.
Yeah. So you can sort of see rectum here. The anus is going to be down at the level below the level of the pelvic floor muscles. So if we follow these in a series of CT images that we have here, we can see our sacrum, and then we look immediately anterior to that for viscera, which will be distal bowel and rectum. So you can see it sitting immediately anterior to the sacrum here. We can see it coming down. We can still see a little bit of air in it here. And then we hit these structures. What is this that I'm outlining just here?
Is it your pubic rectalis?
Yeah, it's one of the levator ani muscles. We can sort of see them. That's probably our puborectalis coming through as this sling, because we can sort of see it at the level of the pubic bones just here. And so right at that level of our puborectalis muscle will be our anorectal junction. And then if we went inferior to that, we would probably be with seeing just the anus. The anus has what we call sphincter muscles. So a sphincter, we have them at enclosures to openings. So we will have sphincter muscles at our junction between our esophagus and our stomach, our distal sort of stomach area, where things need to open and close. And so you can sort of see the anus here, and you've got these muscles, and they sort of allow something to open and close like that. And that's what we refer to as sphincter muscles. So when we do a cross section through here, it looks quite round, but we can see the sphincter muscles, these sphincter muscles here in cross section. Hopefully I've got some views of them. Oh, just here. Can you see here? We're below the level of the levator ani muscles. We're down a bit more inferior, and this would be the rectum here with some sphincter muscles. Can everyone see that? So we probably have sort of rectum, anorectal junction, and then anus down here. Probably just in this view on the MR. It's not as clear on the MR. So we've got sort of rectum here, and then we'll have our pelvic floor muscles, and that will be our anus area just through there. Is everyone sort of following that?
Yeah. Yeah.
Here you can actually see the difference in the angle between sort of the rectum and the anus, and that's what we call that anorectal junction, which can change as these pelvic floor muscles loosen and tighten. Here you can see this anus, and you can see it's round. It's probably just at the level of the puborectalis. I would probably call that the puborectalis muscle because we can see the pubic bones in there. And so this will be the level of our anorectal junction or the start of the anus area here. Above it, we're going to see the rectum. I think we've covered this. I've just got these in for you to follow and follow as it comes down to become the anus down here.
Sorry, Michelle, are you able to go back to that previous slide for a second?
This one?
So, yes, thank you. The bottom picture on the left, it shows the rectum, and then the one on the right shows the anus. So how, I guess, without the markings on there, what's a good reference point to know?
I would tend to think, look for your levator ani muscles, and you're not going to get something that's vague. Generally above the level of those or at those levels, it's generally rectum. This one, it would be probably anorectal junction if you're going to be absolutely academic. And then below the level of those muscles will be anus. That's a really better way of thinking of it.
Yeah, thank you.
There's always a junction of these things. And so it doesn't just all of a sudden become the other structure. And so there's always going to be an intermediate sort of area where they're turning from one to the other. And so sometimes an answer is not going to be necessarily completely right or completely wrong at those junction areas. So don't, remember, I'm marking them all as long as it's reasonable and it's rational thought. And if you get it in a quiz and it's one or the other, think it doesn't have to be, you know, it might be one or the other. And the quiz will have all of the answers together, need to make a whole of the answer that needs to be correct. And the quiz questions will ask you for the most correct answer.
Okay, no worries. Thank you.
And you can see as we follow it down, and then it's just generally gone. This is sort of your butt crease. Remember, the person's lying down and their two buttocks are squished up against one another. So sometimes on a plain x-ray, you sort of see a dark line in the plain x-ray here. So some people get a bit of air that gets caught in there. So on an x-ray, it looks quite dark. You're like, what's that line? It's just air caught in the butt cheeks sometimes. Okay. The urinary tract, we'll move on to that. Your urinary tract is basically what makes wee, I suppose, in total lay terms. It filters out, the kidneys are like little filters for your blood, and they extract the bits that you don't want and gets rid of the extra volume of fluids that we don't need in the body and will excrete them. It sits in the bladder, which is like a holding bay until it accumulates enough. And so the ureters are tubes that connect your kidneys down to your bladder. And then you excrete that wee or urine, as we call it medically, out through a distal tube called your urethra. So you can see the words ureters and urethra are quite similar, and it's important not to get them mixed up. So ureters are the connecting tubes which connect your kidneys to your bladder. The urethra is what you pee through to do a wee into the toilet. There's little junctions between the ureters and the bladder, which we call a vesico-ureteric junction. So another word for the urinary bladder is vesico. So think of the urinary bladder as a vesicle or a holding device for wee. So the junction is the vesico-ureteric because it's between the bladder and the ureter junction. And we often call things when they have really long names in anatomy acronyms, like the, three-letter acronyms, TLAs. And that one we would call the VUJ for vesico-ureteric junction, where the ureter meets the bladder. And that's important because I'm going to show you some of those, because we look at that junction with ultrasound and we want to see wee coming through from the kidney and coming into the bladder. We want to see that both kidneys are excreting the urine uniformly and symmetrically, because that's going to determine their function and how much, you know, if a kidney is not functioning properly, it won't be excreting much urine, and, you know, there can be problems, and we can actually determine that a little bit with ultrasound. Is there any questions about the components of the urinary tract?
All good, I think.
Yeah, all good. Yeah.
So the urinary bladder, or the vesicle for holding urine, I'll call it the vesicle, so that you get used to that vesicle terminology. It sits posterior to our pubic bones and our symphysis pubis. So the symphysis pubis is the joint between the two pubic bones. So when we had a look at our CT scans and we looked at the two pubic bones here, you can see that it looks like there's a space in there between them. There's actually cartilage that lines these two pubic bones, and there's a little bit of a joint there because there has to be some movement in there, particularly for when a woman has to give birth. You need a little bit of movement in there. And so the space in between the two pubic bones is called the pubic symphysis or symphysis pubis. As I said, anatomically, there's all these variations and things that we can call it. Can everyone see what I'm referring to when we talk about the symphysis pubis? On this X-ray, you can see the little gap in there. Can everyone see that?
Yeah, thank you.
See how the gap is midline? So if we've got a mid-sagittal picture, often that's like right through the symphysis pubis. If it's a parasagittal picture, we're going to get a picture through the pubic bone. So right here, they've called this the pubic symphysis because it's saying it's an absolute mid-sagittal plane, right in the midline. So this is the space between the right and the left pubic bones. When we say something sits behind or posterior to another structure, we use the term retro. You think, you know, retro clothing, it's back in time, it's back, it's behind an era. So this, we have what's called the retropubic space, which is the space that sits immediately posterior to this pubic bone and this pubic symphysis. So there's a bit of fat here in this retropubic space, and then there's the bladder. Can everyone see the terminology I'm using there?
Yes, thank you.
So when this bladder is empty, because the bladder changes constantly in its volume, we're sitting here and if I've had lots of sip of my tea, and tea has a diuretic in it, so it makes you sort of excrete more fluids, my bladder might fill as I'm conducting this tutorial for the 2 hours of it. I may need to go to the toilet. So my bladder might go from this amount of volume up to like nearly up to my belly button, considering if I've drunk a whole lot of water prior to the start of the tutorial. So when it's empty, it's going to sit with a small volume, and as it fills, it's going to get bigger and bigger and bigger, and it's like a balloon. So it has a muscular wall and it changes in volume. So when it's relatively empty, it sits posterior to this pubic symphysis, and then as it fills, it's going to get larger. And as it gets larger, it's going to have an impact on the structures that sit behind it. So in the female and the male, it always sits posterior to the pubic bone. The structures that sit posterior to the urinary bladder are going to change depending on whether there's a uterus there in the female or there's seminal vesicles there in the male. Can everyone see that?
Yep. Yeah, thank you.
And then posterior to those structures that sit posterior to the bladder will sit the rectum. And then therefore we have spaces that sit anterior to the bladder or posterior to the bladder or posterior to the uterus, but anterior to the rectum. And so there's all these relationships of structures that we need to appreciate, and little spaces as well. So we said the bladder sits immediately posterior to the symphysis pubis, but it's also the more anteriorly located organ in the pelvis. So let's go and have a look at our CT scans. We're through our iliac bones here. We can see our sacrum, our sacral foramina. We can see some anterior abdominal wall muscles, which we'll get to in week 3. And then there's this big balloon-shaped structure that sits out here. So this bladder is quite full. As we go through it, it starts off looking round, and then as we come down, it has more of the shape of this cat here. Can you see that? You see how it looks very similar to that?
Yeah.
And so as we look through, you go, oh, there's the cat head. It's anterior. That is going to be our urinary bladder. So think of the urinary bladder as the cat head. I drew very dodgily, sorry, some eyes and a nose and a mouth in there to give you the visual of the cat head sits most anterior. It sits posterior to these anterior abdominal wall muscles. As we move down, you can see that it's sort of, in this case, is sitting superior to the pubic bones because it was quite distended. And then other organs and structures will sit inferior or posterior to that. Everyone thinks they can identify the urinary bladder in the CT?
Yep.
Yep.
Okay. Sometimes when it's not that full, it may not get that kitty-catty looking shape. So these are some MRs. This is not as full, so it's got more of a square shape. Can you see it's more of a square or a rectangular sort of shape in these images here? And that's just a less distended bladder. All bladders, when we look at them, will have different volumes in them. I just threw in a sagittal and a coronal CT scan just to help you pick out where the bladder is sitting. So let's have a look at this coronal CT scan. We have our iliac bones here. What bones do you think we're looking at here?
The pubic bones.
Pubic bones, yep. And the little space is representing what?
The pubic
symphysis. Yep. And then there's a structure which we can sort of see. It's sort of rounded. We can sort of see it has a wall, and then it's got contents which are all a homogeneous density, or a we would call that on the CT. And what structure is this going to be?
The bladder.
Bladder.
Urinary bladder, that's right. Here's our pubic bone. We're not through the symphysis. And can you see this structure just here? That's where our urinary bladder is sitting on this sagittal reformatted CT scan. You can see these are our anterior abdominal wall muscles here, and it's sitting immediately posterior to those, and posterior and slightly superior to the pubic bones. Everyone can see that?
Yep.
Can you see the wall of the bladder? Because it's got these muscular walls, and then the lumen, what is within the lumen of the bladder?
Urine.
Urine, yeah, urine. We just call it urine. Perfect. So then on ultrasound, I thought I would introduce some ultrasound images because it is important that you start looking at these. We always look at structures in at least two planes sonographically. If we have to take a volume, and we often measure the volume of a urinary bladder to see how much someone can hold and to see if they're emptying out their bladder properly. So this is a transverse view of the bladder on ultrasound. Fluid shows up as black, or what we say as no echoes, so anechoic. And so this is the urinary bladder on the CT scan, and this is the corresponding, what we would call as a transverse image of the urinary bladder on ultrasound. So this is the right side of the image. This is the left side of the image. This is anterior, and this is posterior. The same as this is the right side of the image, the left side of the image, anterior and posterior. Can you see how this and this is matching up?
Yep.
When we do the ultrasound image of the urinary bladder, we're basically putting the probe on the anterior aspect of the abdomen, but just immediately above the pubic bones. So whenever everyone starts ultrasound, and you'll all be the same, we'll say, get a picture of the bladder, and everyone puts the probe, because no one wants to go near the gonadal region, and everyone puts the probe up near the belly button. And we're like, oh no, you're never going to see the bladder down there. Like, remember how close it's sitting to the pubic bone here. So to see this, we have to put the ultrasound probe just above, because we can't see through the pubic bone with ultrasound, just above the level of the pubic bone. So it always feels like you've got the probe down near, you know, the pubic area, because you do, and then you have to image that. So just remember, we're going to be putting our probe right down here. It means that sometimes our images are not completely axial like they are with the CT scan. So that's why we call it transverse and we call these axial. Axial means it's completely axial. Transverse means it's in the transverse plane, but we can have some sort of tilt on the image. This is a longitudinal image. So this is, again, longitudinal image on ultrasound. This is towards the patient's head. This is towards the patient's feet. And this is anterior and this is posterior. It's a little bit different to the orientation of what we're looking at when we look at this is a mid-sagittal image, or this sort of an image on the MR. So what happens is you've got to turn the MR sort of image all around. And I've tried to spin it around here. And this is one thing where you're going to have to sit there and think about it, because it's a different concept, the way we orientate images with ultrasound. This is generally towards the head in a long axis view, and this is towards the feet. So towards the head is up here, and towards the feet is down here. And anterior is this, and posterior is towards the spine. So we're going to have more rectum sort of area out this direction. So this is the posterior aspect of the bladder on this image, and this is the posterior aspect of the bladder on this image. Bit of a head spinner, that one. We'll get used to it. We'll look at a few more images. So you can see the transverse sonographic view. The bladder still looks sort of square or rounded in shape. So it still has more the kitty cat head. Sometimes you can see the ears, sometimes you won't. And in the long axis view, it nearly looks a little bit more triangular in shape. Nearly think of it as a side-on view as the cat's nose. You'll tend to see it, if it's full enough, in more, can you see it's more triangular, Nellie? It's got points in it. And that's the view we tend to see when we see a long axis view of the bladder. So I've just got some images of a bladder that I acquired from the Royal Brisbane Hospital. This is just a patient. I've taken their names off. These are transverse views. So you can see it doesn't quite have the kitty cat shape. It's a bit more round because it's actually a volume, and we measure the volume, and it's like 687 mils. That's actually quite a lot of fluid in a bladder. This bladder was a bit distended. This patient, I don't know if you can see this round thing here, they had what we call an indwelling catheter, a catheter in their bladder, which we'd clamped off to hold the urine in the bladder to allow us to see it properly. So we take a transverse view and we take a longitudinal view to measure the volume. The average volume of someone before they feel like they need to go to the toilet, most people will say they need to go to the toilet at about 250 to 300 mils, or we talk in cc's as well. So that's, you know, probably about a cup in your bladder, and you usually feel like, so this is 3 cups, Nellie, in the bladder. So that's why it's not a kitty cat looking shape, it's more round. I've got a left ureteric jet and a right ureteric jet. What do you think these things, these red bits here, might be indicating?
Urine entering the bladder?
Yeah, urine entering the bladder from the right vesico-ureteric junction coming across that way, and the left vesico-ureteric junction, which will sit on this side, and it shoots the urine across coming up this way. So we can turn colour Doppler on. This is a B mode image and this is a colour Doppler image to show the movement of, often it's blood, and we're seeing blood here with the blue, but we can see the movement of tissue as well. So we can actually see the movement of urine. And these are fairly symmetrical, meaning that the right and the left kidneys are draining nicely into the urinary bladder. This, I said, is showing a blood vessel. Who wants to have a go at what this might be indicating? It's sitting lateral to the bladder, the urinary bladder, in the pelvis area.
Internal iliac artery? Or is it too high?
You're very close. It's probably our external. It could be our common iliac or probably external. Our internal iliacs are really actually quite small. But yeah, it's going to be one of our iliac vessels. Probably more either our common or our external iliac, because it's coming a little bit more anteriorly, possibly our external iliac, but excellent for having a go at that. I'm going to see. So here's our bladder. Do I come up here? Can you see that we have vessels on either side? And we talked about our external iliac vessels moving from here and coming more anteriorly as we move down. Can you see these vessels? And when I turned the colour on, I was showing a vessel here and vessels here. So can you see how our particularly our external iliac vessels sit immediately lateral to our full or distended urinary bladder? Can everyone see that from those CT scans? So we looked at those the other day, and then when I come down to this transverse view, this is which vessel would this be here? Right or left?
Right.
Right.
Yeah, because this is the right side of the patient and this is the left side of the patient. So we've got probably our, we don't even know if it's a vein or an artery from this image, but it's the right-sided iliac vessel. Excellent. So when we take this transverse view, it's sort of an angle between a transverse and a coronal view, really. When we take our depth down, we can see structures that sit sort of inferior and posterior to it. So this is actually showing our prostate and our seminal vesicles, and we'll get to this shortly. Normally the bladder wall should be nice and smooth. Does this bladder wall look nice and smooth here? No, it's got lots of little outpouchings, and we call those diverticular. You don't need to know the pathology. I'm just showing you what an abnormal bladder wall looks like. And the bladder lumen, or the inside of it, should be completely empty and just have urine in it. Is this bladder lumen completely empty?
No, it's got a mass in it.
It's got a mass in it, yeah. So it's got a tumour that's sitting in it. So to help us identify this, we have to know what the normal sonographic appearances and anatomy look like. And is there a structure that normally indents that lumen of the bladder? No, so that's abnormal. So here we can see these vessels. Can you see them on both sides? So we can see right-sided vessels and left-sided vessels. This is a bladder when it's completely emptied. So we have a look at the bladder before they go to the toilet and after they go to the toilet. So we can, when someone goes to the toilet to do a wee, we call that micturation, or they've voided. And so we can call it a post-void or a post-micturation image, but you can see that it becomes very small. It's not even got 1 mil in it. So you have to know where you're looking to see that bladder you know, it's going to be very hard to pick it. That's the volume of the bladder, and you can sort of see it's got a thicker wall around it. We're only measuring the contents of it there. This is a bladder of a female patient. This is in long axis. Can you see that it looks a bit more triangular here in long axis? And you can see it has more of that kitty cat appearance in transverse view. Can everyone see that? What structure do you think this is if it's in the female and it's sitting immediately posterior to the urinary bladder?
Uterus.
Yeah. So this is towards the head. It's a longitudinal view, and towards the feet, this is anterior and this is posterior. So we have the urinary bladder. We have the uterus here. This would be the cervix, and this is the vagina here. And then this is stuff that sits posterior to the uterus, and we're not actually able to see to the sacrum area. Who wants to have a guess at what this is in here?
Gas.
Bowel, gas in the bowel and bowel. Yeah. So we'll probably have bowel and then more rectum down in this area here. We also have to look at
just a question in the chat. Sorry.
No,
That's
thank you. Where was the vagina? The vagina is this area here. So the vagina is a collapsed area. In the transverse image, this is the female. So this is anterior. This is the urinary bladder. And this area here would be the vagina. And this would be the rectum back here. So this is from anterior to posterior, urinary bladder, vagina, and bowel or rectum here. This is just looking at the bladder a little bit higher up, and we can actually see the uterus sitting posterior to the bladder, and then there would be bowel out here. So we can take levels, transverse levels at all different levels. So this image would be with the ultrasound sent in through this level because it's showing vagina. And this image here would be with the ultrasound sent through this level where I'm sending my arrow. Does that make sense? As I said, the ultrasound images are not completely axial as they would be in the CT. We can angle the probe, and we do angle the probe through multiple different angles, which is a benefit that we can do that, but sometimes the images don't correlate exactly to a CT or MR image because of the angle that we insonate or send sound in at structures. We haven't covered the uterus and the things this week, so don't get too worried if you're not picking out other structures just yet. I've just got this in here. Often we have to have a look at the bladder in a mother that's pregnant, and so we might be looking at the bladder of a fetus in the fetus, and then we'd have a look at the bladder of the mother. So there's, in the one tummy, we're looking at two different bladders. So we would call it the fetal bladder and then the maternal bladder, meaning the bladder of the mum. And so sometimes, you know, the maternal bladder is very squished if the mother is very heavily pregnant. This will be all baby up here, and just a little bit of the mother's bladder down here. Just different things to think about. The urethra, the bit that you're going to pee the wee out from, is going to be completely different in males and females. In the males, it's much, much, much longer. It's shorter in the females. So there's quite a distance that it has to go through in the males. So in the males, it's going to come down and come all the way through the penis. In the females, we have our bladder here, and the urethra just has to come out this distance. And you can see the urethra. How would you describe the position of the urethra relative to the symphysis pubis? on this mid-sagittal sort of view here.
Posterior.
Yeah.
Yeah, it's immediately posterior to the symphysis pubis because it's a midline structure. It's posterior to the symphysis pubis in the male, but it also sits inferior and within the penis as well. Let's just follow some CT images down. What do you think we're looking at just here or here? What do you think that might be?
Yeah.
Colon?
Iliac artery.
This one's probably a bit of small bowel. That's a bit tricky. We're going to have our aorta here and our IVC, and then they're going to bifurcate into some of these vessels, but sitting sort of a bit out to the side is going to be a bit of small bowel there, and that would probably be a bit of large bowel. That's a bit more abstract for you to pick out. We've probably got a little bit of small bowel in here. It's just not opacified by the by contrast or anything. Let's go down. What's this structure here?
Bladder.
Bladder. What do you think this structure here is?
Obturator internal.
Yeah.
Yep.
Sorry.
Right.
Right. Obturator
Right.
internus muscle.
Obturator internus muscle. Remember, it's a muscle because there's going to be tendon that sits out further as well. So yeah, it's a muscle. So remember, you need to call it the name of the structure that it is. What is this here going to be?
The rectum.
The rectum. Can anyone have a guess as to whether this is male or female already?
I'd say it's female just because you can't see the formation of like the prostate in the last picture.
It's actually
Or actually,
male.
maybe that's the seminal vesicles.
They
Is that the
are.
seminal
They
vesicles?
are.
Okay.
These are seminal vesicles. So I'm just pointing that out because we're going to cover the seminal vesicles today, and they sort of look like little bow ties that sit behind the urinary bladder, and we see that on ultrasound, we see that on CT and MR. So you weren't expected to know that. That was just seeing if anyone could pick it out, but very good for having a go. It can be really hard to pick it out, but once we know where our seminal vesicles sit, they sit posterior to our bladder in the male, and you can see that they sit posterior to the bladder but anterior to the rectum. Can everyone see that? And then so if it's a male and we come down, there's a structure that's sort of inferior to the bladder and a little bit posterior to it. So who wants to have a go at suggesting what this thing here might be?
The prostate.
Yeah, prostate. So can you see how following a series of images is important to help you work out what's what? And then you can start to pick out that these other things will just be muscles as well, and we'll cover those later. And then we can sort of start to see the penis and testicles coming. When we get to the male genital organs, we have like external and internal organs. We scan the testes and the epididymis and the scrotal region quite a lot because there's a few changes that can go on with those. You can get infections, you can get tumours, you can get inflammation, cysts, all sorts of things. We occasionally have to scan the penis. It's not a common thing that we have to scan, but saying that it's always probably when you least expect it, probably more in hospitals. But we certainly scan the urinary bladder and the prostate and the seminal vesicles very routinely in males. The testes, they produce sperm. They sit outside. Can you see them here on this sagittal MR sitting outside? So if you follow this down, this is sort of the bottom, and this is anterior and posterior, and so you can see a testis sitting down here. But it's definitely inferior to the level of the the pelvic floor and inferior to the level of the symphysis pubis. We have what's called the testis, and then we have a structure called the epididymis, and then we have a tubular structure called the ductus deferens. They're sort of the main components that you need to understand. There's some information in the Draw It to Know It, just to get used to the order in which those structures sit, what is more close to the body and what is more, I suppose, distal. So the testis is the most distal structure. It's the furthest component that's away from all of these tubes from the trunk or the main part of the body. So when I say things are more distal and more proximal, it means it's closer to the body, and we'll use those terms. The very outside bit of the testis is called the tunica albuginea, and we actually can see that. This is an ultrasound, like a short axis view. So if this is the testes are sort of like an egg, you know, and you've got like the long axis of the egg, and then if you were to cut the egg in half or short axis and cut through the egg, this would be a short axis view. It's just sort of, imagine that's the long axis of the egg and we've cut through it, and that's a short axis view. So the reason we use long and short axis is the testes don't tend to just sit like two eggs that sit up and down. They can twist and turn and sit on all different orientations to the body. And so when we image them, we tend to talk about the long axis and the short axis of that structure. Does that make sense, what I'm talking about? If not, we will develop that terminology, because we'll use that terminology as we move on to talk about like the long axis of my arm and the short axis of my arm. It's the same sort of thing. It's of a structure.
So with that bottom picture, was that a transverse plane though?
Yes, you would call it trans because it's transverse through the short axis of the structure. We tend to use that.
Got to get the axis and the transverse planes all separate in my head.
Yeah. In ultrasound, we often will call the short axis trans, as opposed to, you would say there's long and there's trans. So long is long axis and trans can be the short axis. Does that make sense? And that's why I'm referring to axial as the slices of the CT and the MR images, because they are a complete axial plane.
Yes, it does. Thank you.
No worries. So you can sort of see the long axis of the testis is in an axial or a transverse plane of the body here. Can you sort of see what I'm talking about? The long axis of the testis is running horizontally at this point. So this axis, this long axis, is sort of lying across like this. When we talk about the long axis of a structure, we will say that it has a upper and a lower pole, meaning upper meaning closer to the body, and lower meaning more distal and further away, I suppose. So we use that in ultrasound, probably not so much in when we look at this image, but when I show you the ultrasound images, you will know what I mean. So I've sort of tried to, I just drew a very basic diagram here to outline the components that are important to understand at the testis. So we will have an upper pole and a lower pole. We will have where the sperm drains, it drains into the epididymis, and there's a head, which the epididymal head sits superior to the upper pole of the testis. And then the sperm's going to drain down into the epididymal tail, which tends to sit down near the lower pole of the testis. And then it does a loopy-loop and it comes up through the ductus deferens, which is then going to come back up into the internal parts of the body. So it's a bit of a weird concept to understand. This is always weird because it looks like it's going back in, whereas this bit here is running along the outside, this ductus deferens, and then it has to come in through sort of your inguinal canal, like your groin region, to come back into your body, into the inside part of your pelvis. So all of the sperm has to drain out and then come back to the body. When someone has a vasectomy, I don't know if you've heard of vasectomies, they actually do a snip of this ductus deferens here. And so that stops sperm going back into the body to be excreted out through the penis. So there's a disconnect of the connection of where the sperm's made, and so it can't make someone pregnant. When that happens, sometimes you get dilatation of all these little tubules because the sperm has nowhere to go. So we see dilatation of all these tubules on ultrasound. Can you see this? This is a normal testis and it gets a little bit dilated here. So we can see this area that we call the reti testes, which is where all the sperm sort of drains into a collecting area. It can get a little bit dilated. So that reti testes is an important component. You can see it in here. It still sits within the testis itself. So this whole thing is the testis. And so when that gets dilated on ultrasound, it'll look like there's a dilatation of one component of the testis, because that reti testes still sits within that, what you would say, egg-looking component of your testes. Am I making sense?
Yeah, are you saying that that happens just immediately after they get a vasectomy, or does it stay that way?
No, it may not even happen at all. You just see it on some people. Yeah, it's just one of the changes that we may see. No, there's lots of people that have vasectomies and you don't see this. If we do see it though, we're not worried about it. It's not anything to get worried about. It's just the way different people react to it.
So would you see that on someone that hasn't had a vasectomy before?
No, you shouldn't. If you certainly saw that on someone that hadn't had a vasectomy, you would be thinking it was something more sinister. Which is where getting your clinical details from your patient is very important. And never assume by the age of someone that they haven't had a vasectomy as well. Speaking from many people that I've worked with or like scanned, some people can be very young and have had one.
Men seem to have no issue getting a vasectomy, unlike us women who want hysterectomies, and they're like, you're too young.
Yeah, so you never quite know someone's prior experience when you're in the room. You do a bit of questioning, but you never make assumptions about your patients. That's another thing. So here's the egg, the long axis of the egg of the testis. And if we did a slice through this long axis, we would call a long axis view, which will give us this subsequent view where the testis looks like an egg. Does that make sense? Because it's an ultrasound image, and this is really important to understand, this side of the image needs to be towards the head, and this side of the image needs to be towards the feet. So the way we hold the transducer needs to make sure that that's the case, which means that this is the upper pole of the testis, and this is the lower pole of the testis. This is the upper pole of the testis and the lower pole of the testis. We spin it around, and this becomes the upper pole of the testis on the ultrasound image and the lower pole of the testis. Is that making sense? It has to be that way so that universally, when other people are interpreting the ultrasound images, if there's a tumour that's sitting here, we say the tumour is sitting in the upper pole of the testis. I mean, generally the whole testis is removed. If there's a tumour, unlike a breast where you take out a lump, you tend to take out the whole testis if there's a tumour there, but you need to say where it's sitting and does it correlate with how the patient is feeling their lump and things like that. Am I making sense so far?
Yes.
Yes, thank you.
The testis should look, what we say, homogeneous in echo texture, because that's what all of this tissue should look like on an ultrasound. If it's not homogeneous in echo texture, and this little bit of change here, this could represent the reti testes once again, which can look a little bit brighter or echogenic, or what we call the mediastinum testis as well. that's considered normal. But generally, the whole testis needs to be homogeneous. If it's not, and we're seeing a focal area of decreased echogenicity, we would call it, that may indicate a tumour. It's very important that we, diagnose that to guide the patient management. So we take, as I said, we image everything. We have a long axis and a short axis view. So that's the long axis view of the testis, which looks like an egg, and that's the short axis, what you may say transverse view of the testis. So the testis looks more round in the short or the transverse view, and more oval or egg-like in its shape in long axis. Still following? Yep.
Yeah.
So we do
All
some
good.
measurements. Was that a question?
No, just letting you know that it was all good.
Okay. So this is the long axis of the drawing that I've sort of drawn. So this will be towards the head and towards the feet on this image here. Towards the head, we see this bit of tissue. It looks the same echogenicity of the testis, but it's separate from it. It's got an E. So what do you think that means it's standing for?
Epididymis.
Epididymis. Do you think this might be the epididymal head or the epididymal tail?
Head.
Head. Why did you say head? Or was it just a guess? Because that's fine.
Because it's towards the head.
Because it's towards the head. So this is the, as I said, the sperm comes out of here. It comes up through the epididymal head first. It travels down, then it goes down through the epididymal tail, which will sit at the lower pole, and then it's going to come up through the ductus deferens. So it's going to, the sperm's going to come out through the epididymal head, travel down through the epididymal tail, and then travel posterior through the ductus deferens. So near the upper pole of the testis, we're going to see the epididymal head. Towards the lower pole of the testis, this is the lower pole of the testis, we're possibly going to see the epididymal tail as well. Should be the isoechoic or the same echogenicity as the testis. So here's a long axis view. This is the upper pole of the testis, the lower pole of the testis, and you can see the epididymal head there. We sort of can't quite fit the epididymal tail on. This is the short axis view. It says this is the left testicle, so we're going to know that this is going to be more lateral and this is going to be more medial, because on the other side we're going, so this is both testes. So this is the right testis and the left testis in short axis. So we're doing a cut that's straight through both testes here. We want both testes to be the same echogenicity. We want both testes to have the same amount of blood flow in them. Is there the same amount of blood flow in this colour Doppler image of both these testes?
No.
No.
No. See, this testis is actually what we call torted, and that means it's spun around on its axis and its blood supply has been cut off. But we can't tell that just by a B mode image. We can only tell that when we start to turn the colour on. So using just one view and one type of ultrasound does not allow for a diagnosis. So there's a lot of things involved, which you will learn about. Because the testes at this stage still look like they're roughly about the same size and shape as well. Usually when that blood flow gets torted off, the veins are squishy. So the veins which take blood away from the testis, they cut off first. So the artery blood can go in and the venous blood supply gets blocked off. Usually the testis swell and then it torts a little bit more and the arterial supply gets cut off as well. If the arterial blood supply gets cut off, the testis gets no oxygen. Therefore it needs that to keep alive, so it can die. So it's a bit of a emergency ultrasound and emergency procedure to untwist and detort that testis. So you can see that we scan these testes quite a lot. So understanding the blood flow to them, understanding the structure of them is quite important. So this is the epididymal head, that's the epididymal tail. This is going to be the upper pole of the testis and the lower pole of the testis. So if this is a long axis image, what pole of the testis are we looking at here?
Upper.
Upper, that's right. Here's a long axis image. This here is the epididymal tail. It's not the same echogenicity as this testis. Looks like that it might be a little bit inflamed in something we call epididymitis. Itis means inflamed. If this is the epididymal tail, what part of the testis do you think we're looking at here?
Lower pole.
Lower pole, yeah, because this is towards the head of the image. This is towards the feet. Our upper pole of the testis is here. This is the lower pole of the testis, and this is the epididymal tail. So you've got the epididymal head, the testis, and the region of the epididymal tail. Might have epididymal body. We don't tend to see the ductus deferens. It's really, really small. There is a scrotal sac, and so sometimes you can get fluid that sits in between what we call the visceral and the parietal layer of the scrotal sac. When that's there, that's called a hydrocele, hydro meaning fluid in the sac. The visceral layer is always the closest layer of something near the organ. So this is the testicle, it's the organ. So our visceral layer is closely opposed to that. The parietal layer, think of it as older or outer layer, always sits further away. And so there's separation between those two layers. Normally there's a tiny bit of infinitesimal bit of fluid in there to allow those testes to move around. We don't want too much in there. If someone has a knock to the testes, that might become blood. We can call that a hematocele. So heme stands for blood. Can everyone see that layer between the visceral and the parietal layer of the scrotal sac? So the scrotum is the sac, like the bag, and the testes sit within that sac. And they're surrounded by it. So the testes are the organ or the viscera, and the scrotum is the sac or sort of the protective layer. Like, think of it, Nelly, like the airbag in a way. We need to protect those testes. They're important structures for the continuation of the human race. Okay.
There's a
schematic-
question in the
yes.
chat, Michelle, sorry.
Oh, no, good. Tunica vaginalis. So a lot of the structures are similar in the male and the female. So tunica vaginalis is the layers. And so once again, you can have different terms that mean different things. I will probably get to tunica vaginalis. So what happens is your testes actually start and they're developed up inside your body, so inside your pelvis. And then they have to travel outside the body so that they're at a more even temperature, so that for sperm production. Some people, the testes don't travel all the way out. They have to travel through your inguinal canal. So they have to sit up in your pelvis, sort of near your bladder. And then when you're a fetus, they travel through your inguinal canal, which is a tiny little canal in your groin, sort of about 2 centimetres above your groin crease, as I showed you the other week. And then they travel and they descend down to sit in the scrotal sac. The tunica vaginalis, there's a whole lot of tissues that have to guide the testes down into eventually sit in this sac. So some people, their testes don't do that, and they have what we call undescended testes, which mean they can sit at any point in time where they've stopped traveling between the pelvis, either in the inguinal canal, like sort of in the groin, or even just a little bit at the distal end of that groin. But if they're sitting down in the scrotum, they're fully descended. So the tunica is the tissue that guides, and you can sort of see it was sitting up here, and the tunica had to guide the tissue, the testis, all the way down, and then it distally envelops it down here. So the parietal and visceral layers are layers of this tunica vaginalis, and this sac, this cavity is where fluid can accumulate in here. So often when babies are born, they might have fluid sitting in there, and they can often have really swollen scrotal sacs, and it usually just dissipates after. And that's just because it's not been long since those testes have descended from the pelvis down into the final scrotal sac region. And sometimes when babies are born prematurely, their testes won't have descended properly. Is that helping to understand that?
Yeah, that's great. Thank you.
So here you can see the testes, they sort of actually start all the way up near the kidneys, then they sit near the bladder, and then they have to move all of the way down. We don't cover embryology in this unit because there's just too much to cover. But that's it in a synopsis, really. And the ductus deferens, they have to move with the testes because they have to drain. They have to drain the sperm through. They're going to bring the sperm all of the way up into the body. Then they're going to join with these seminal vesicles that is going to give some more fluid to the sperm. It goes through the prostate, then it comes out through this duct and it joins through to the urethra, so that the same tract that urine travels to come out through the distal end of the penis. So that ductus deferens is just a duct. We don't really see ureters on imaging because they collapse down. So anything that's a tube that is not carrying stuff all the time can collapse down. So they're really quite small and hard to see on imaging. So you won't really have to point out your ductus deferens on any of your medical images, but you do need to know where they sit. Any questions?
No, thank you.
The testes sort of have the same vascular supply as the ovaries in the female. The ovaries obviously sit inside the pelvis in the female, but once you get the vascular supply to the testes, you've got it sort of for the ovaries. We have testicular, or what we call gonadal arteries. You'll often see them referred to as gonadal arteries because that refers to them in the male and the female. They're going to be ovarian arteries in the female and testicular arteries in the male, or gonadal arteries for both. So those terms can be interchangeable as long as you're pertaining, if it's testicular, you're referring to a male, and ovarian, you're referring to a female. So they come off the aorta, and remember, arteries take blood away from the heart, and they take oxygenated blood to a structure. So the testicular arteries are going to take oxygen to the testes, and your testicular veins or gonadal veins are going to drain the blood away. These little rings indicate your inguinal canal that sits sort of at your groin, sort of a bit above that groin crease area. So they come up through the inguinal canal, then come back into the tummy or pelvis, and then the arteries are the same. The veins, the right testicular vein drains back to the IVC, your inferior vena cava. Your left, for some unknown reason, I have no idea why, it drains up and it drains into the vein that drains your left kidney back to the IVC. So it doesn't do a direct course back to the IVC, inferior vena cava. So it does this indirect course so it drains into what we call the left renal vein. Renal is a term that pertains to your kidneys. So when we do an ultrasound of your kidneys, we do an ultrasound of your renal tract. It's called your urinary tract, renal tract. It's the same terminology. So your renal veins, they drain your kidneys. Your renal arteries will take blood to your kidneys. So your left testicular vein comes all the way up to your body, and it does this 90-degree turn into your left renal vein to drain back to your inferior vena cava. Your inferior vena cava is going to take blood up to the right atrium of your heart. Because they drain differently, this one has no issues draining because it comes back and it drains into the IVC at sort of a nice angle. Because this drains back up against and has to do this 90-degree turn, we often get dilated veins down here on the left side. And on ultrasound, we'll see these are all dilated veins. They all look like big worms and ultrasound, we actually call it the bag of worms appearance. And so we call that a varicocele, like dilated varicose sort of veins of the testes. So we often see that on the left, and it's because of this different drainage of the testicular veins from the right and the left sides. So you can get varicoceles on the right side as well, but it usually will happen first on the left. The symptom is, well, because there's all these dilated veins, often the patient can feel a little bit more swelling around the left testis. Often they're more prominent, more towards and sit above the superior pole of the left testis. So you can see this is a long axis view. This is more towards the head and more towards the feet. And we can see the left testis here in the upper pole of the left testis, possibly a little bit of the left epididymal head, and we can see all of these dilated veins. So someone can usually feel a bit of swelling around their left testis, maybe more towards the superior aspect of their left testis, and it gives a draggy sort of pain with standing or sitting for long periods of time. It's not comfortable. You can get them on the right side, but it's usually that you'll see it on the left side first. I don't know if that's answered your question, Riley. Okay, we're going a bit slowly, but hopefully we're developing it. So I've drawn this diagram that hopefully will explain where the sperm goes. It's in the left testes, comes out through the left epididymal head, closer to the head, to the left epididymal tail, closer to the feet, goes through the ductus deferens. It's going to go through your groin, and it's going to go into your pelvis cavity, and then it's going to come down. This is your seminal vesicle, sort of looks like a floret of cauliflower, the way I've drawn it there. It's going to add some sort of lubricating fluid. It's going to come into via the prostate and then down and out through the urethra. Can everyone sort of follow that path that I've tried to draw here? This here is a view of a blown up urinary bladder, and we're looking at the posterior aspect of it, and this is the seminal vesicles. So sort of you can see they're nearly the colour of cauliflower, and so your ductus deferens will come and join to these seminal vesicles, and then they're going to all drain into this walnutty sort of thing here is the prostate, and distal will be this way. This is more towards the head. This is an unusual way of looking at it because we're looking at the posterior aspect of the bladder, where the vesicles sit. Yeah.
When the ductus deferens, when the sperm comes along and joins up to the urethra, is it like a valve or something which stops contamination? Is in there, or is something? How would it?
Yeah, there must be. There would be a little sphincter. See, there's a little. You have little sphincters that happen
so
in
that
here.
just
So these
closes that
muscles.
up
So you
and
have a urethral sphincter at either end. Yeah.
So that's
Good
just,
question.
yeah. Okay.
Yeah.
Good. Thank you. Don't want it mixed up now, do we?
No. No, the body is amazing. There's lots of
That's how you
smooth
end up having
muscle.
little wee babies, eh?
No. There's a lot of things we don't have to think of. Luckily, the smooth muscle we don't have to voluntarily think about. So the smooth muscle, a lot of these sphincters are involuntarily controlled, and there's amazing neural pathways that take care of that for us, thank goodness. Yes, my goodness, if my body had to rely on my neural pathways, nothing would work properly. Too many things to remember. So we've talked about the seminal vesicles. We commented on them and said, look, they look like a little moustache that sit posterior to the bladder on the CT. This is a sagittal. So this is anterior and posterior. S stands for superior and inferior. You can see the urinary bladder here, and you can see the seminal vesicles sitting immediately posterior to this urinary bladder that has some amount of urine in it. So when we do the axial view through here and get this is anterior and posterior, and you can see the seminal vesicles sit posterior here relative to the urinary bladder. You can see that? You sort of see them sitting down here on this diagram. Often they do sit up a little bit higher. They can be a little bit bigger, that they can vary in size. So they won't always be the same size. You'll see on different CTs that some will look a little bit bigger and others, and you see that on ultrasound as well. Where on this image are you going to say that the seminal vesicles sit relative to the prostate?
Posteriorly.
Yeah, posterior-superiorly, I would suppose. So you can often combine those terms. So yes, it sits a little bit posterior, but it also sits superiorly. So we would combine those terms and you can say posterior-superior or superior-posteriorly. Just have a go. But can you see the combination of those terms is more correct?
Okay.
Yeah. Oh, where's my little eye? Oh, there we are. Oh, I drew it on there for you. So I put a cat with a bow tie and see how it looks like the kitty cat wearing a bow tie. And so when you start to look at your CT images, if you see the bladder with the kitty cat and it's wearing a bow tie, it's most likely going to be a male. I drew a button in there because if it gets really formal, the button could be the rectum as well. So sort of for your male and your CT scan, think, oh, there's a kitty cat, got a bow tie, and it's got a button, and I'm thinking urinary bladder, seminal vesicles, and rectum. Don't think that that is your prostate, because you're going to need to go inferiorly to see the prostate. Don't get your prostate and your rectum. What's that?
I never realised the pelvic area had so many animals in it. There's an elephant, there's a bat.
Over the years, I've tried to deconstruct it to make it more memorable, because if we go through all these things, you're just like, I'm never going to remember that. Visuals, honestly, it's all about pattern recognition and building up pattern recognition, and any way that works helps. So when you're talking amongst yourselves, help make the more stupid things that you can use as visuals to remember, you just want to remember them. That's all. Like, and then the visual will help you think this is anterior and this is posterior. So remember, this is the most anterior part of the cat, and this is posterior on this image.
Kind of looks like a hat on the cat.
Yeah. Yes. Yeah, it's got like, that's going to be your rectus abdominis muscles. So yeah, if you draw a little, I don't know, think of something to put up there, and they will be your rectus abdominis muscles. We will build it up slowly, and then you could say it's like, yeah, I don't know, think of what the iliac vessels are out to the side. So on ultrasound, these are really old ultrasound images. I don't know why I had them, but this is like the kitty cat transverse view of the bladder. And then it's still going to have the seminal vesicles sitting behind, and they still do look like a bow tie appearance on ultrasound. Remember that on ultrasound, we can take those transverse images at multiple levels. This is a long axis view. So this is towards the head and this is towards the feet. So this is the superior part of the bladder and the inferior part of the bladder. This is the seminal vesicles and this is the prostate. Do you see how I was sort of saying this is superior relative to the prostate, which is inferior? Can everyone see that? Yep.
Yeah.
So this is a transverse image of the urinary bladder and the seminal vesicles here. And this is a picture of the urinary bladder and the prostate. It's hard to show the seminal vesicles and the prostate in the same transverse view, because you have to take one transverse view image this way at this level, then I need to change the orientation of the transducer to get an image of the prostate at this level. So this first line here is showing this transverse image. This blue line here is showing this transverse image. Does that make sense? And can you see the different angles that we can send the transverse images through the body at?
It makes sense. It's just so much harder to recognize them on ultrasound than it is on your CT and MRIs.
Yeah. Which is why we focus a bit more on CT and MR at the start. So these are some pictures that I just took of a patient at the hospital. This is a transverse view of the urinary bladder. This will probably be the rectus abdominis muscles here. This is the urinary bladder. So this is anterior and this is posterior, but this is also anterior superior and posterior inferior, because the angle at which I'm intimating in on the male will be sending the ultrasound in on an angle like my hand is showing. Does that make sense? I'm not coming in at a direct transverse orientation. So you can say that the prostate is sitting posterior-inferiorly, really, relative to the bladder, the urinary bladder. This is that long axis view. So this is towards the head and this is towards the feet. What structure is this here?
Seminal vesicle.
And then what structure is this?
Is that part of the prostate?
Yeah, this whole thing here is the prostate. Just this bit here is really the seminal vesicles. Yeah. And so then if I send a transverse view in at this direction, more superior part of the bladder, I will see the seminal vesicles sitting through here. See how it's more flat looking? I mean, it's just more flat relative to this, which is more round. The prostate truly is the size of a walnut and the shape of a walnut. So think of the prostate as the walnut. In some people, the prostate gets to be the size of a grapefruit, and you know, a walnut is not supposed to be the size of a grapefruit. And so that also means that the prostate pushes into the bladder and it can be hard to pee out of because the space for the urethra gets a lot smaller. And so that can happen as males get older. The prostate, it's not that there's anything wrong with the prostate, it just gets enlarged. What structures do you think these are here? They're more flat looking, posterior to the urinary bladder.
The seminal vesicle.
Yeah, it's looking more like a moustache or a bow tie rather than a walnut. What does VAS labelled on the prostate? Where was that? Did I have VAS? I can't even see where I had VAS labelled. You might need to let me know where that was labelled. I can't see it.
It's from in a lecture.
Oh, in the lecture. I can't think. I'd have to have a look at the image to see.
Would it be like this? This silly. It wouldn't be like vasectomy, would it? For a vasectomy, VAS.
It could. Sometimes the seminal vesicles can. No, they don't tend to get dilated.
Would it represent the vas deferens?
We don't tend to see the vas deferens sonographically unless something's wrong with it. I'll have to go back and have a look. I can't off the top of my head work out what it stands for. What are these bits of colour showing again?
Urine flow.
Yeah, so these are emanating. So can you see there's a little lump here? That little lump is the vesico-ureteric junction, which we often will call something. So this would indicate the left vesico-ureteric junction because it's where the ureter is going to join the bladder, which is a vesicle, and then send urine into the bladder, and this would be the right vesico-ureteric junction here. I think
Sorry,
that's
Michelle, could you go over the junction, the ureter junction thing again, where it's shooting from? I'm getting a bit confused with my left and right.
Yep. So this is the right side of the body, and this is the left side of the body. The junction, the right vesicoureteric junction will sit on this side, and the left vesicoureteric junction will sit on this side. So just say the ureter comes down in this way, the urine is coming from the rest of the body, and then it's going to shoot the urine across. So the urine ends up going from right to left. So you've got to see where this lot of colour is emanating from at about these little lumpy bits just here. Does that make sense?
Yeah, that's better. Thank you.
Yeah, it's a concept. You'll have it and then you won't, and then you'll have it and you won't again. So it's one that sit and digest it. But always go back. This is a transverse view. This is going to be the right side and the left side of the patient. There's our iliac vessels showing up there on the right side.
I did find that picture, sorry, for that person who asked about the VAS. It's on your ultrasound image where you have the I can't even say the word, ejaculatory ducts, and you've got the ejac ducts, then you've got SEM-VESP, and then you've got VAS underneath that. Yeah, so I don't.
Right. Yeah. Oh, yeah, it's probably just so you're going to have your bladder, your seminal vesicles, your ductus deferens, and then this is usually your ejaculatory duct that comes through here, joins with your urethra. Yeah, if I don't know what it is, I don't think you need to know. I'm probably referring to vas deferens, or if it's on a diagram, because you can call this ductus deferens the vas deferens as well. Once again, anatomically, there's just multiple names for the same structure. Very confusing, I know. Wait till we start getting into eponyms where radiologically we call things after someone's name. It's really frustrating. The prostate on the MR, you can see it's not easy to see, but you know that it sits around this urethra, so you know the region in which it sits. So you can see that it's sitting around these structures right here. So it's just this little, and this is a cross section. So you're seeing more the ducts through the middle of it. If we went parasagittal to this on either side, you would probably see more consistent prostate tissue like we see in the ultrasound. We don't see the ducts through the prostate on ultrasound. Ultrasound is it's a fairly coarse image of the prostate that we see sonographically. Occasionally they can do biopsies of the prostate. If they ever have to do a biopsy of the prostate, they often do them transrectally. So something goes into the rectum and then through this way. Doesn't sound very nice, doesn't sound very, you've got to make sure everything's nice and clean. But you can see why they would do transrectal biopsies, because you can see the close association of where the rectum and the prostate sit in relationship to one another. How do you describe where the rectum sits relative to the prostate?
Posterior.
Yeah. Okay. They're just some older images.
Superior a little bit too?
What's that?
Is it superior a little bit?
It can sit superiorly, but I think you say the direct relationship would be posterior. So when you say superior, you tend to go to the structure of interest and look superior to it. So what structure would you say would sit superior, directly superior to your prostate?
The bladder.
The urinary bladder, yeah, as you can see here. And that's why your seminal vesicles, you would say posterior-superiorly relative to the prostate is where they sit, but posterior to the urinary bladder. We have little things called bulbourethral glands. We can't actually see them sonographically. We don't really see them on imaging unless there's something wrong with them. They have a little duct that also empties into the urethra. They do sit in that, what's this pouchy thing called here?
Perineal pouch.
Deep perineal pouch.
Deep perineal pouch.
We don't really see it too well with imaging. It's just important to know that they're there. These little things here are the sphincter muscles. See how we have little sphincter muscles at the exit of the vesico-urethral junction, and also around the distal end of the prostate. We have other little sphincter muscles as well. Don't get too caught up with all of the names of all of those sphincter muscles. It is important that you know that they're there, but they're not structures you're going to visualize on imaging unless you're doing specific transrectal ultrasounds, which we can perform, but you tend to only perform them in specialized areas. And they're not a routine sonographic examination. So we've got a male pelvis. We can see our symphysis pubis here because we're midline. We can see our urinary bladder. We can see the muscular wall of the urinary bladder. What's sitting up here, do you think, superior to this urinary bladder when it's distended?
Colon, and I think part of the bowel.
Yeah, probably small intestine because we're right in the middle.
Yeah.
Remember the bowel, the colon sits more around the periphery. This is a midline image. So we probably have more small intestine sitting in here. We have our sacrum, we have our coccyx, we have sort of rectum, we have our seminal vesicles, we have our prostate, we have our urethra, and there's different components of that urethra. And then we have our rectum. Below the level of the pelvic floor, we're going to have the anus area. The penis has lots of different components. I've covered them in the lecture. The main thing to know is that we have the urethra. The urethra sits in spongy tissue, so we call that the corpus spongiosum. So the urethra is going to carry sperm and it's going to carry urine. And then we have sort of muscular, not really muscular, but very vascularized tissue called the corpus cavernosa. And these corpora, or one corpus, two corpora cavernosa, have arteries that run through the middle of them. They can just be called deep arteries. We tend to call them the cavernosal arteries because they sit within this corpus cavernosa. So it's really important that you know that there's three main components, because if you do have to do an ultrasound of it, you're going to see these three main components and you need to work out which is which. And the most, and this is a bit of a visual thing, sorry, but I just drew this just before it started. This is literally what it looks like. It looks like two big round bits and a flat mouth. And to me, it sort of looks like the emoji face that you're probably going to do when someone says you have to scan the penis. Now, you're going to do this emoji and think of this emoji and think, oh, that emoji has three main components and they're what I'm going to see on the ultrasound image. You're going to see two big eyes, your bulging eyes coming out of your head going, why me? And your patient's probably going to be doing the same thing. So you're all collectively going to be doing the same thing. And then it looks more flat, the corpus spongiosum, because it's spongy and it's squishy and it's flat. And you don't even see, because it's a urethra and it's a duct, and you're not going to see it unless something's passing through it, it's collapsed. You don't really see where it is. So this visual is really important to embed in your brain because it's always when you least expect it that you have to do this. But if you know the components, it's going to be easy. This is also these corpuses, two corpus cavernosa. If we turn the colour Doppler on, we can see the artery. The artery is probably this because arteries have really elastic walls. And this is just a B mode image. But right in the middle, this is an MR, there would be little arteries, which we can't see on the MR. But this is a cross-section of the penis on MR because these are the testes, and this is a cross-section on the ultrasound. So the key is to note that there's two corpus cavernosa, which are the same size, and then there's the other one singular component, which is the corpus spongiosa, which contains the urethra. These will contain our, because they're the corpus cavernosa, cavernosal arteries, which could be the eyes. Does that deconstruct this? Focus more on this and think of the main three components that you're going to see on imaging. There are also some other little vessels that sit in here that we will see as we scan. We do have to scan this for a few different reasons. Sometimes these arteries can get a little bit calcified. There can be all sorts of different injuries and things that we may need to look for. So it is important to know that you have these cavernosal arteries and then other arteries. Do the other arteries sit at the same side as the spongiosa or the opposite side?
Opposite?
Yeah. So you know that your other arteries are going to sit outside the corpus cavernosa, but the opposite side to where the urethra is. Does that break it down? So here, the eyes, the mouth, the other little arteries, I think we've covered that in a nutshell. I only had to scan one the other day and I did save the images, but I was trying to find them this morning and I must have like about 20 different USVs sitting here right next to me because I often put them in my pocket at the hospital and I could not find it. So yeah, at some stage I'll find it for you. If I find it before Thursday, I will share it with you. What component are we looking at here?
Corpus spongiosum.
Yep, and then we've got the corpus cavernosum. We do sonographic examinations called a cavernosogram, where we have to explain, we have to demonstrate the blood flow in these corpus, the cavernosal arteries. There's all sorts of interesting procedures that we get to be part of. So here's another short axis sonographic view. We've got two bits that are the same side, then a squishy sort of bit. What do you think I've labelled it for you. Number 3 is showing the cavernosal artery. Can you see how it's like they're quite a bit more echogenic because arteries have like multiple layers of walls to them and they've got this connective tissue. And as we saw on the CT scans, the arteries stay quite round and veins would just be squishy. So we're not actually seeing any veins in here. That's the spongiosum, and you can actually see the area of the urethra, which is collapsed on this view. Other views, cavernosa, spongiosa, and the region of the urethra would be sitting in here. Any questions about that? No? Axial MRI, do you think this is male or is it female, and why?
Is it female? I'm looking for my little bows.
Okay, so sometimes the little bows are going to be these things, and see how they've got lots of little dots. Sometimes you will see them on the MR as more little spotty sort of areas.
Okay.
Yeah, so this is going to be our rectus abdominis muscle, so a very anterior part of the tummy. The white's all fat. Our urinary bladder, seminal vesicles, rectum, sacrum, right obturator internus muscle. We can see our obturator internus neurovascular bundle. We can see our pubic bones here. We can see all the way to our ischial spine. Who wants to have a go at what that little dot is there?
Pudendal nerve.
Pudendal nerve.
Which one?
Oh. the right.
Right. What do you think we might be looking at here?
Right, coccygeus muscles.
Coccygeus muscles, that's right. So we've got our right femoral head, our right acetabulum, our left external iliac artery, and our left external iliac vein. Using our NAVY, we know that our arteries sit more lateral to our veins. Feeling like you're sort of okay with looking at this as I go through that? Getting there?
Yeah, getting there.
Might even have a bit of our sacrospinous ligament here on the left, sitting posterior to our coccygeus muscle. I've got some labelled, they've called that iliococcygeus. As I said, those muscles blend with one another. It's academic as to what we're going to call some of those. In the coronal plane, this is showing the urinary bladder and the prostate and the urethra coming through it. We would have to take a coronal view more posteriorly to show the rectum view. So we're not going to see that in this. This view, this is a transverse view, but I've got that it's really a coronal view. Can you see how we sort of see the bladder and the prostate is nearly inferior, but we tend to think of it as posterior. But as I said, it's because we're angling the probe down on a nearly often it's like a more than a 45-degree angle down. So it ends up being more coronal than axial on that ultrasound view. So these are when we're looking at the pelvis, we would do a long axis view. You can see the probe is orientated in a long axis view. This is towards the head and this is towards the feet. Really, our probe would probably have to be down here. This is probably a new sonographer that's got the probe up near the belly button. Won't see anything. And can you see the angle that I'm talking about? See how this is not a straight axial view. And that's why it makes the prostate look inferior to the bladder. So that's just important to appreciate. So we get our long axis view. I've sort of drawn the diagram and shown where things sit. So you can see the urinary bladder, you can see the seminal vesicles and the prostate, and that's the region of our symphysis pubis. Can you see how that marries up to this sort of view here? And so when I was saying we look at this sagittal view, but really when we do an ultrasound, we're going to be showing it more like this orientation when we do the ultrasound. You might need to sit and take a bit of a time to understand that, but does this help with thinking of the orientation? Can you see this is the bladder here, this is the bladder here. This is your symphysis pubis, which is this thing here. So this is towards the head and this is towards the feet. This is towards the head and this is towards the feet. And then we know that we're angling down. So we put the probe on the pubic bone and then put the probe immediately above it because we can't scan through this. And then we sort of angle down. So we can see seminal vesicles posterior to the bladder and then usually the prostate posterior and really inferior to the bladder. I think I've covered that. Does that visual help? Hopefully.
Yes.
So these are just some, I found this. So I've got this reference here and I'm cognizant of the time. I am just going to bring this up. I found this on Wikipedia. I don't know how I stumbled across it, but this, just because it's hard for me to say the whole scroll of images for you, the size is huge. So I'm just going to screenshot this and it's much easier and you can have a play with it. So it's a Wikipedia thing and I've put the link down in the notes and this is exactly what we do in a radiology department, is we can actually, this is the way we look at things, we scroll through. So I'm going to scroll through and you can see where the slice is acquired from with the yellow line. So this is posterior. This is posterior and anterior. So posteriorly, I can see my sacrum, my sacroiliac joints, my iliac bones. I can see my femur here. And I can see my vertebrae, I can see a bit of kidneys, psoas muscle. As I scan through, I can see my iliac bones, I can see acetabulum and femoral heads. And then I scan through, I'm just scrolling with my mouse, just using the little scroll button and rolling it up. What do you think these things are coming through here? What do you think they are?
Common iliac artery?
Yeah, well, we've got our aorta and our IVC. Our aorta is sitting to the left side of the IVC. We've got the bifurcation of the vessels. See how the bifurcation is just above the level of where the top, well, it's at the level of the iliac crests, really, isn't it? Just above that. So that's the level of where your belly button would be sitting. And then you've got your right and your left common iliac vessels coming down. Can't quite see where our internals, they would have to be coming off more posteriorly. There's probably our internal iliacs there. Oh no, that's more anteriorly. Probably our internal iliacs coming off down here somewhere. So these are probably going to be our external iliac arteries. I'm coming more anteriorly because I can see my pubic bones and my pubic symphysis, and I can see my urinary bladder. I can see my right external iliac artery and external iliac vein at about the level of the pubic bone. It's going to be common femoral artery and common femoral vein here. But I can see my urinary bladder. I go back, probably male. Hard to tell. I'm not getting you to pick that out on this. And then I'm coming through anteriorly and I'm coming through to my rectus abdominis muscles. So I just thought you might like to have a play with that. You can also scroll through with the sagittals, and these are the ones that I've included in here just so that you're not feeling too unfamiliar with them, but you can have a scroll through yourself in real time. So yeah, I just found that little thing. Have a play with that as well. I've got some more CTs for you to go through. I think we have sort of gone through quite a few of these of the male structures. It shouldn't be looking too intimidating for you. And that's sort of what we covered today. Does that help to bring it all together? I think that was it. Yeah, and we're finishing just in time. A lot to get through.
That's great. Thank you.
But we have deconstructed, I mean, a lot of those structures today. We've sort of joined them up. We've sort of looked at where they've sat. We've sort of picked them out on a few images. We've introduced some ultrasound images to get you used to thinking of what's towards the head, towards the feet in your long axis images. Get your rights and lefts in your short or transverse axis images. Remember to do that for the testes because it's a much smaller area and you don't have that big relative part of the body to compare it to. But start to think big, but also start to think small as well, so you don't get flustered. Any questions? I think everyone's a bit exhausted. Can you see that some of those CT images are even starting to come together from last week? We're building.
Yes, it does help. It does.
Yes. Yeah. So last week it was just like, oh my goodness. And then this week you're like, oh, hang on. I'm seeing the things we saw in last week and we're building and it's coming together, hopefully. Anyway, I will let you go. I'll stop sharing there.
Thank you so much. As always, it was good fun.
If anyone wants to share any visuals, feel free at any stage. Like if you're finding something helps with learning, be collaborative, share some ideas, because anything that you can laugh at and share at together it'll help you remember them and try and make it fun. Sorry, I hope some of my pictures weren't too overwhelming or ridiculous. But sometimes
that
the
emoji face. We won't forget that one.
It's always awkward. No one ever wants to say the name penis or vagina or testes.
I've got I don't know whether anyone else have an issue. Just with your cursor being small and black, sometimes it moves really quick over your black scans.
Oh,
So
okay. If you've got a tip on how I can make it more obvious.
Well, you can just go into your settings and change like your mouse settings, I think it is, and you can pick up the speed of your cursor. You can adjust that, like how fast it moves.
Oh, okay.
Comparison to the actual mouse, and also you can change the style and the
what style do you like?
Well, I think maybe something that contrasts, maybe a white over the black screens or something, I don't know, or a bigger one.
Okay.
You can even have ones with little tails that as they go across, it leaves a little flash so people can see where it's going.
Okay.
I don't know if it's everyone or just me, but sometimes it's a little hard to see where you are.
Okay, thank you for that. I will change it to it's hard because you're going between black and white backgrounds. So maybe a different
if it's
color.
just bigger as well, or
orange. Maybe I need to have it orange or yellow.
Not sure whether you can go that far, but I don't know. Maybe check it out. Yeah,
okay.
I don't know.
Thank you. I will.
All right, thank you.
That's okay. See you.
Michelle, we won't have to do that in the lab, will we? Like practicing on our fellow students?
Oh no, nothing internal, nothing private parts. No. That's why it's easier to deconstruct that anatomy though, because out on clinical placement you can't sort of shy away. But no, you're not practicing it on anyone. The only thing you're practicing on each other is just tummy things. Yeah. No, we've actually got a testicular phantom that you can scan because testes are fairly common, and it's, as you can see, it's an emergency ultrasound, so it may be something that you can get called in the middle of the night even to scan. But no, you're not scanning anyone else in the lab's testes or anything like that, and no internal scans or anything. No. I can totally allay those fears straight away. That's what simulation and phantoms are very good for.
Michelle,
yeah,
I have a question about the exam. I believe everyone asked about it, but again, just to be sure, is there exams on the actual like CT scans or an ultrasound scans, or it can be, or it's on the
the images that you'll get? It will only be images we've gone through and deconstructed.
Right. Okay.
Yeah.
Right.
So any images that we sort of look at in these lectures and tutorials are the ones you focus on.
Right. Great. Thank you.
Yeah. So these notes, label them as much as you can and go through and label them. You'll find that a really good activity. I just sent that email out just so that, I was just getting a few, we have to just be so cognizant of that. We have to demonstrate to the ASAR that we get people to actively learn, and that we are not, here's the notes, just copy them and do a test. Because just because you have accreditation doesn't mean that it's there forever. It's a constant thing you have to update and show.
Right.
But no, it doesn't mean that I'm going to give you really abstract things. It's only things that we will have covered in these tutorials and study groups.
Perfect, thanks.
And Sally just said, will the practice images be assessed in exams too? So lectures, tutorials. So it's the tutorials and the study groups are the things to focus on. The lecture content just clarifies information for you and makes you know, you have heard the topics that we talk about. It explains things, because I really do have to go through what structures are before we start going, here they are on a medical image, and this is where we're looking at where they sit. So that a lot of the definitions of what they are is provided in those lectures, whereas the unit is relational anatomy and image recognition. So they have to be the main things that you get tested on in the tests. Is, can you recognize structures from medical images? So to start with, most of the stuff is image recognition stuff, because to recognize stuff on an image, you actually need to understand where it sits relative to other things. It's in the layers of thinking.
Michelle, I think there's a cursor or a laser pointer within Zoom. So next time you show images, I think it's like in the pen tool or something. But yeah, you could just look that up.
Let me just have a.
Because
I might even try and I'll share my screen again now.
Because Kathleen used something like that for last unit.
Oh,
yeah.
Annotate. Ah, here.
Yeah, I think there's like a laser pointer as well.
Oh, okay. So I can spotlight it with this. Okay. I will just have a format, and I can make it really fat. Yeah, like that.
Yeah.
Is that better if I like draw on stuff?
Yeah, probably to mark out on like the black and white images when it's quite harder to see.
Yeah. Okay. No,
That's great. We can see that really well.
Okay. Well, we'll leave it as pink, because I don't think any of the things are pink unless I've drawn them in. And that should stick out. I wonder if it'll save that setting. Save. I just know. Just remind me if I'm not using it the next study group. Just go, Michelle, pointer, and just call it out. I'm not at all offended. Just as long as I'm making things so that you can see them. So thank you. Always bring things to my attention. I like it. Yeah, I can learn just as much from you as you can from me.
Every day's a learning curve, right? Every day.
I learn every day. I truly learn just as much from you as you do from me. Any other questions? No? Okay.
Have a good week. Have a good week. Have a good week.
You too. I'll see you again on Thursday. You see a lot of me.
Bye.
Bye.